Hello, everyone. Good morning. Welcome back to Department of Medicine Good Grand Rounds. We are continuing our senior Grand Round lecture series where we highlight some of our amazing PGY3s coming up. Today we have another two additional great PGY3s. We first have Dr. Gavin Hall. Dr. Hall first went to Princeton, where he obtained the very easy to obtain physics degree. Bachelor's degree in physics, and then afterwards he then decided that his life was not hard enough and went to medical school at Northwestern in Chicago before he finally came here and joined us in residency. Today he's going to be talking about a very interesting disease that has vexed a lot of physicians throughout the years, VEXAS. So as a quick reminder, please hold all your questions until the very end after both speakers have talked, and please help me welcome Dr. Hall.
Hi, everyone. I'm Gavin Hall, and I'm here to talk to you guys about this newly described disease, VEXAS syndrome, basically from the perspective of what a general internist or someone practicing at our hospital in a general capacity ought to know about this. So this isn't too subspecialized. It's not what a rheumatologist or a hematologist ought to know, just what I think kind of generalists ought to be familiar with. So my goals are really just to gain familiarity with the clinical features of this kind of newly described disease and when you all should consider it in a differential diagnosis. And then my other goal is to kind of talk a little bit about the implications of this disease and why I think it's an interesting disease that changes sort of how we think about traditional rheumatologic classification and diagnosis. So a case from our case files and from some specific case files that might be familiar to some of our audience today. It's a 77-year-old man with excellent functional status, minimal past medical history, presenting with a fever of unknown origin for 6 weeks. This actually isn't his first presentation. He's had 4 hospitalizations over the last few months. Initially, he presented for rash, fevers. He was diagnosed and treated for cellulitis. He was noted to be pancytopenic at this admission, and their plan was ultimately for an outpatient hematology follow-up for this. Several days later, he came back with recurrent fevers. They hypothesized this was a drug reaction from his first antibiotics. He was observed for several days and then ultimately released without treatment. Finally, he came back more ill for a third presentation, continued fevers, increasing shortness of breath. At this point, he was found to have diffuse pulmonary opacities, bilateral pleural effusions. At this point, he underwent an extensive workup, including bronchoscopy with BAL and a transbronchial lung biopsy that was unrevealing for any infectious cause and only showed an organizing pneumonia on biopsy. Skin biopsy that was nonspecific, bone marrow biopsy without any signs of a hematologic malignancy, infectious disease and rheumatology consultations with extensive serologic workups that were unrevealing of any systemic cause for his syndrome. He was treated with antibiotics for a course for a pneumonia and then ultimately was once again released. And then he finally presented again for his 4th admission, this time in distributive shock and with a diffuse skin rash. He required vasopressors initially, and at this point was started on stress dose steroids when he had a vasopressor requirement. He seemed to notably improve during this time in terms of his hemodynamics, his fever curve, and his rash. And ultimately, he was transitioned to prednisone and continued on steroids on discharge. He didn't really have a unifying diagnosis at this last hospital discharge. There was some talk of whether he had adult onset Still's disease or another acquired autoinflammatory disease. Ultimately, he was referred to our rheumatology clinic for a second opinion after discharge on prednisone. Ultimately, he was diagnosed with VEXAS syndrome after DNA sequencing for his peripheral blood at that appointment. So VEXAS is this novel disease. It was initially described in 2020. And how do you discover a new disease in the 2020s? That doesn't happen so often. VEXAS came out of this group at the NIH that was really interested in familial inflammatory diseases, so things like familial Mediterranean fever or other kind of syndromes like this. These are pretty rare, and they're not terribly clinically relevant on a day-to-day basis for most internists, but they're notable because we understand their causes much better than we understand the cause of kind of most adult onset inflammatory or autoimmune disease. And they were specifically interested in a kind of ubiquitination pathway that they thought might be implicated in inflammation, and they were really interested in finding new genes that would be implicated in kind of familial fever syndromes or familial inflammatory syndromes. So they collected a whole bunch of whole genome sequences from people with kind of atypical inflammatory disease or undiagnosed diseases at the NIH, And they screened all these whole genomes looking for kind of shared variants in these genes associated with ubiquitination. Ultimately, they found 3 guys, all men, who had a mutation in the same allele of this UBA1 gene on their X chromosome. They shared all significant inflammatory disease as well as anemia. And then searching through their further cohorts, they ultimately collected 25 total patients with this mutation. And they published this initial case series in the New England Journal in late 2020, proposing that it was basically a novel syndrome and a new disease based on mutations in this gene. So I'm not a molecular biologist, and I don't care that much about molecular biology, but I just want to talk briefly about what this mutated gene is and where it is, because I do think it's relevant for this. So the UBA1 gene encodes this enzyme that kind of is one of the main initiators of ubiquitination in the cell. And ubiquitination is just this kind of very flexible post-translational regulatory process within the cells. And when they looked at these men's genotype, they found that this mutation was only found in certain cells in their peripheral blood. So that is to say, some of their cells had this mutation and some of them were wild type. And when they examined their families, none of these men's families had this gene. And so based on the heterogeneity within individual patients and the lack of any familial spread, they determined that this was kind of a somatic mutation. And specifically, it was a somatic mutation that was only present in kind of myeloid cells within their blood and myeloid precursor cells. So they had totally normal, unmutated T cells, totally normal, unmutated B cells. However, their neutrophils, their monocytes, and their myeloid precursors tended to be dominated by this acquired mutation that they had had at some point in their life. And the kind of myeloid precursors that were mutated that they found have these kind of characteristic vacuoles that they saw in bone marrow biopsy when they initiated this. So they named it this very bulky name that's an acronym. So the V stands for these vacuoles that they saw in the myeloid precursors, E for the enzyme that is mutated in this disease, X for the chromosome that it's on, A because they all had significant autoinflammatory features, and S, given that it's a somatic mutation. This is not something these men were born with, it's something they acquired throughout the course of their life. Since then, we don't discover a new disease every day. There's been a whole flurry of scientific papers. There's been a bunch of articles in the popular press about a scary new disease that's been discovered. It's been featured on the successor to House MD, Chicago Med. So what have we learned about this over the last few years? My first goal is to give you guys sort of a sense of what this disease looks like and when you ought to look out for it. The initial, I think, caveat to this is that the clinical features are highly variable. There's this one underlying mutation, but what's come out since this disease has been published over the last few years is that there's a very wide range of clinical presentations that all come from this one mutation. So while we can kind of talk about what clinical features are shared, I just want to emphasize that this is a very diverse disease from the start. In some sense, that makes sense. If there were a very consistent clinical presentation to this, if there were a very narrow range of phenotypes, we probably would have discovered it before 2020 just by our basic powers of observation. And the fact that we didn't, I think, speaks to the fact that this can cause a great many things here. So what can we say about it? This is a disease mostly of men that happens late in life. It's, as you would expect from an X-linked disease, more than 90% male, and it's very rarely seen before age 50s. It seems to increase with increasing age, as one would expect as well from an acquired mutation. There have been some reports of women having this, either with Turner syndrome or with very skewed X inactivation, but that's very, very rare. The majority of these people have significant constitutional symptoms with fever, with weight loss, with elevated inflammatory markers. They're obviously quite obviously inflamed. And they're generally sick. They often require sustained high-dose glucocorticoids for symptom control, and they end up using a lot of healthcare. So organ system by organ system, there have been some kind of through lines or characteristic manifestations. Hematologic manifestations are extremely common. Over 90% of the patients that have been described have anemia, which is typically macrocytic and tends to progress over time. A substantial proportion also have other cytopenias, either leukopenia or thrombocytopenia. And in fact, a substantial proportion, in some series it's about half, in some series it's a substantial minority, meet criteria for myelodysplastic syndrome based on the basis of their bone marrow morphology in addition to their cytopenias. this picture up here is a myeloid precursor cell with these kind of characteristic vacuoles that you can see on bone marrow biopsy. And as well, venous thromboembolism is very common throughout this. Skin involvement is also almost universal and seen very commonly throughout the disease. It can look from the surface like a lot of different things, and it can histologically look like a lot of different things. Neutrophilic dermatosis and things that look like Sweet syndrome have been very commonly described, as is cutaneous leukocyte aplasia. So some examples are kind of shown here. Then additionally, lung involvement is seen in about half of cases. And as far as I can tell from the literature, it doesn't seem to have a particular radiographic sign that you can tell. So ground glass has been described, frank consolidations have been described, pleural effusions have been described. As far as I can tell, there's not a characteristic pulmonary manifestation, but pulmonary inflammation and pulmonary disease is quite commonly seen. And then finally, there's a wide array of connective tissue manifestations. Chondritis is very common, kind of as exemplified by this very inflamed ear up on the screen. And in the initial case series that they published, a substantial proportion of men had been taken from the NIH's cohort of men with relapsing polychondritis. Subsequent case series have shown that probably a decent minority of men who had previously been diagnosed with relapsing polychondritis are likely secondary actually to this VEXAS syndrome. Vasculitis has been reported of any size vessel, small, medium, or large. And then an inflammatory arthritis has also been reported, though characteristic features of this are not really well documented in the literature that I can see. So it can do all these different things to all these different organ systems. How would you practically diagnose this, or how does one diagnose this? You need to find the mutation that defines this disease. You need genetic testing, ultimately. At WashU, we conveniently have built our own, or our hematologists really have built a convenient next-generation sequencing assay that tests for like 50 genes that are commonly mutated in myeloid malignancy. The one we care about is the UBA1 gene, and that's one of the 50 genes that we test for. And so this is called the MyeloSeq platform. We built it, we made it, and anyone can order it in Epic. So if you type in MyeloSeq into Epic, you can order this, no special privileges needed. It might be expensive. And so that's how you make the diagnosis, is ultimately you have someone with a compatible clinical syndrome, someone with inflammation, and then you find this genetic marker. There's no real clear criteria on who to test at this point. There's no guideline on who should undergo workup for VEXAS syndrome. There's no clear guidance on what sorts of clinical presentations ought to be further investigated. Based on what's been published, the highest yield is probably older men with systemic inflammation and some degree of cytopenia as the highest yield people to investigate this diagnosis in. So the bottom line on clinical presentation is there's a lot of different clinical presentations that are driven by this one underlying mutation. And while there are through lines throughout this, there's not exactly one classic presentation of this syndrome. In the case reports that have been published since 2020, these patients have met classification criteria for a really wide array of diseases that don't classically look like one another. And aren't often cared for by the same doctors. So people have met classificational criteria for myelodysplastic syndromes, for Sweet syndrome, for polyarteritis nodosa, for giant cell arteritis, for ANCA vasculitis, for Behçet's, as well as a bunch of other rheumatologic and inflammatory diseases. It's not to say they were misdiagnosed with this, I think. I think they probably met all these clinical syndromes. That is to say, this one underlying mutation has been reported to drive a really wide array of inflammatory manifestations that on the surface we've thought of as separate for a very long time. One logical question to ask about a new disease is, how common is this? Is this something that I'm ever likely to see in my career as a generalist? If I'm not a rheumatologist at a big academic center, should I care about this, basically? I think we're still learning about how common this is and what the full prevalence of this is. We really only have one decent study looking at prevalence, and that's from a health system in Pennsylvania that had just been collecting a bunch of genomes of their patients, basically pre-existing to this, just for research purposes, and they can correlate this with their complete clinical data. And so after the discovery of this, they went back to their 160,000 whole genome sequences that they'd collected, and they looked through to see how many people have this characteristic mutation. they ultimately came up with a prevalence estimate of 1 in 13,000 for their whole cohort. And in men over the age of 50, they came up with a prevalence estimate of 1 in 4,000. They were able to correlate this clinically with disease, and all of these men had real disease. They all had anemia. Many of them had lung and skin involvement. Quite a few of them had actually been diagnosed with VEXAS syndrome before this study came out. And they also kind of showed the wide range of rheumatologic phenotypes that have been reported in the literature before this. The only other data we have on really prevalence is from an NIH study where they've also been collecting a large trove of genomes up until this point, and they found about 1 in 3,000 people with a typical variant in UBA1. We just don't know much about what these people looked like clinically due to their own manifestations. So how rare is that? I would say it's rare, but it's not incredibly rare. It's more common than lots of other diseases that you guys as general internists know about and probably think about on occasion, like polyarteritis nodosa or IgG4 disease. And it's probably not that much rarer than lots of other diseases that we see not infrequently while inpatient at Barnes Hospital, like dermatomyositis or ANCA vasculitis. I just got off 2 months of FIRM on the general medicine service, and I saw 2 cases of ANCA vasculitis. I saw a case of dermatomyositis. So the diseases that are comparable in prevalence to this are diseases that at least I see in regular practice at Barnes Hospital on the inpatient side. I think based on what we know about prevalence, this is a disease that certainly if you practice inpatient at a big quaternary referral center, you would expect to see at some point, or if you've been in the game long enough, you probably have already seen and just not had the name for it. We don't have great information on prognosis, but based on the reported cases, it seems to be not great. Mortality in case series has ranged from somewhere in the 20s to 30% most commonly, and about half of patients remain persistently steroid dependent, often at a substantial dose of greater than 20 milligrams. We also have very low quality data on treatment. It's all retrospective. It all comes from small volume case studies. There's sort of 2 lines of thought that have been reported in treatment. One of them is to control anti-inflammatory symptoms and manifestations. So steroids are very common, often at high doses. And then additionally, JAK inhibitors have been used, as well as an array of other disease-modifying therapy to try to give a steroid-sparing agent for inflammation. The other line of thought is to treat this more like a myelodysplastic syndrome. That is, there's an abnormal kind of myeloid clone that's causing some disease, even if they don't meet criteria for myelodysplastic syndrome, and to borrow kind of typical hematologic treatments. So hypomethylating therapy has been used, and then there have actually been several reports of stem cell transplant, which at least in theory should be a curative treatment for this disease, as it would basically replace the mutated blood cell with a healthier blood cell. So why should you care? As I already said, this is a rare disease, but it's not that rare of a disease, and it's a serious disease. There's a high morbidity to this, and it has a lot of manifestations. If you practice at Barnes Hospital, this is something that you plausibly might see, and once again, it's something you might have already seen. I think this basically has some degree of clinical relevance to general internists, and it's something that generalists certainly should keep on their radar, should put on their differential diagnosis, and should consider in the right patients, especially since these are sick patients and they tend to concentrate in our hospital from this region. I think you should also care because it acts very differently from most rheumatologic conditions, and it's sort of a paradigm shift in how we think about rheumatologic disease and rheumatologic diagnosis. To take a huge step back, to take like a 10,000-foot view, most rheumatologic, most inflammatory diseases are caused from some misbehaving white blood cell that's causing some damage to your tissues. Now, that's not how we think of them because we can't measure these white blood cells. That's not how we define these diseases. We define them instead by their clinical manifestations. We look at what damage is being done to the tissues, what manifestations are happening in the periphery, and then we group diseases together based on their clinical manifestations. That's part of why rheumatologic diagnosis is really hard for generalists, is because you have to group these people kind of clinically, and that's very hard to do if you don't see enough of these rare diseases. VEXAS is the opposite in many ways. There are some clinical through lines, but there's not really a classic clinical manifestation. there's a wide variety of clinical manifestations that you can diagnose really only from isolating one genetic abnormality. And so as a result, we understand the cause of VEXAS syndrome much better than we understand the cause of, say, giant cell arteritis or ANCA vasculitis. But we understand its clinical manifestations much less well. I think we would hope that, like, each of the clinical presentations that we've grouped in rheumatology for adult onset inflammatory disease would kind of map onto some underlying cause that we'd be able to discover via careful study and careful molecular biology. So, if we study enough patients with giant cell arteritis, we'd be able to understand what underlying abnormality in their white blood cells, what underlying abnormality in their inflammatory system leads to this disease manifestation, and then we'd find a cause or maybe a small set of causes. I think VEXAS at least makes me think that might not be how things work. There might be this kind of cross-pollination of clinical syndromes and whatever is the underlying inflammatory cause of this. So we know VEXAS has one cause, and it leads to a bunch of different inflammatory syndromes that really cut across what we think of as traditional rheumatologic clinical diagnosis. And I'm really curious to see over the next 10 years, over the next 20 years, and over my career, whether we can start taking this approach to rheumatologic diagnosis. That is, we define them by measuring and defining the underlying abnormality in their inflammatory cells rather than by their clinical syndrome. In this sense, it's diagnosed much more like a hematologic malignancy or hematologic disease. Leukemias or lymphomas can look like a lot of different things. They can have a wide variety of clinical presentations. They can affect different organs in different ways. We've all seen this. However, to make the diagnosis, you really have to measure the abnormal clonal white blood cell. I think this is the first in adult onset inflammatory disease where that's been our approach to diagnosis. And I wonder whether it's going to be the start of kind of a paradigm shift in how we think about and how we classify these diseases. There are kind of, in terms of next steps in the research, I think there is, because of this discovery, which has been very novel and exciting, there's been a lot more research into relationships between hematology and autoimmune disease. The obvious one is looking for more somatic mutations in autoimmune or autoinflammatory diseases. There's a lot of research ongoing into the kind of somatic genetics of people with myelodysplastic syndromes who also develop autoimmune diseases, which has been a long-standing observation in the literature. And there's also been very interesting work about somatic mutations in Felty syndrome. But I think this is really in its infancy. I think VEXAS has been the paradigmatic disease that shows that we can find an acquired mutation in life. And then as we think about diagnosis of inflammatory disease, looking more like diagnosis of hematologic conditions, I think this comes in the context of many years of converging treatments for severe autoimmune and autoinflammatory disease with hematologic malignancy. Stem cell transplantation has been trialed in several autoimmune diseases, found to be beneficial, especially in scleroderma. And then this paper from the New England Journal from actually earlier this year was a series of using CAR T therapy for refractory autoimmune disease, which showed remission in quite a few patients and generally great clinical success. So I'm very curious to see if this is the first of many things to come in terms of how we think about and how we classify autoimmune and autoinflammatory diseases over the next years. And I'm excited to see where this goes. So thank you guys for listening to me. Especially thank you to Dr. Frazier and the Chiefs. And then I'd also particularly like to thank Dr. Diffie for talking this through with me. Thank you guys.
Get this started, Beth. Here we go. Okay. Next, we have Dr. Beth Bryant. Dr. Bryant obtained her bachelor's degree in women's studies and history from Wellesley College and then stayed in the Northeast to get a master's in public health from Tufts University. After that, she went to Rush Medical College, where she obtained her medical degree, and now she is here with us as one of our excellent senior residents. Next year, she plans on pursuing a fellowship in geriatrics and palliative care. And in that vein, she has prepared what will be a great talk about hospice and end-of-life care. Please help me welcome Dr. Bryant.
I think so. All right, you guys can hear me? Great. All right, thanks for coming today. I really appreciate it. So we're going to be talking about hospice in the home, a little overview of how we got there, and where we're going to go with it. I have no disclosures, so I figured I'd start with some upbeat questions from you all. Firstly, how many of you have thought about how you're going to die? Right? We're all physicians. I kind of hope we think about that before. How many of you have thought about where you want to die? Okay. And how many of you want to die in your home? Okay. All right. So keep this in mind as we kind of go through the history of hospice and what dying looks like in the home. Hopefully I won't change your minds too much. So really today we're going to be talking about what led to hospice being provided mostly in the home, understand how much it really relies on family caregivers, and then identify some ways we can maybe change the infrastructure of hospice and what you all can do to help support patients and their families. So first we have to talk about dying, though, and what dying has looked like in the United States. So before antibiotics and things like clean water, most Americans died from infection or injury, and these tended to be really quick, sudden deaths. Tuberculosis accounted for about 20% of all deaths, actually, in the 19th century, and that could be pretty slow and agonizing. Americans died in several places. They either died at their home, in public houses, or in almshouses. So for those who died at home, it wasn't necessarily a peaceful, quiet death surrounded by family. Most Americans didn't live in a house where they could have their own space. They lived in a one-room house with the whole family, or they lived in tenement housing. Family members provided most of the care, or they had to hire outside help, which was pretty financially costly. And they didn't have a lot of medications to make dying maybe less painful or less traumatic. And this is a quote from a woman who wrote to her sister as she cared for her husband who was dying from tuberculosis. Quote, "Oh, I cannot tell you the agony of those moments as the breathing grew harder and the film came over his eyes, the blood filling his mouth." So for those who couldn't die at home for various reasons, there weren't a lot of great options. There were hospitals, but as you can imagine in the 1800s and early 1900s, we didn't have a lot of things to offer patients, so they were kind of seen as a last resort. At this time, private hospitals could actually deny patients admission if they thought they were going to die during the admission so that it wouldn't impact their mortality rate. So that's pretty nice. So they would send patients who they thought were going to die to public hospitals, which were really underfunded and overcrowded. This is actually a picture from a New York City public hospital. Patients who were actually called inmates slept 2 to 3 to a bed, and they were so underfunded that they didn't really have nurses, so most of the patients had to provide their own nursing care if they could. The New York Times wrote an article about this hospital actually and said, quote, "The name inspired a feeling akin to terror, for it is to be said that if a sick person must go, it was like the seal of doom." So not a great place you want to end up in. But during the 1900s or the 20th century, medicine began to advance. And the causes of death began to change too once we had things like antibiotics. So death really became more from chronic issues like heart disease and COPD, and then cancer became more well-known and more commonly diagnosed. More people were willing to go to hospitals because there was this new optimism in medicine and its ability to cure diseases. So by the 1950s, about half of Americans died in the hospital. But not everyone was really happy with this arrangement. So many physicians and hospital staff expressed the belief that hospitals were places for people to be cured and not for people who were going to die. There was also concern about cost. It cost at that time about $200 a day to provide care for a dying patient, which in today's dollars is about $2,600. And many people felt that this was kind of a waste of resources. There was also concerns that if a patient couldn't afford a private room, they would end up in a public room like this, so where patients are in lines. And so this dying patient would be in full view of all the other patients. And one physician said that, quote, "This was bringing down morale for the other patients," which is great. So not surprisingly, patients and their families were really concerned that dying patients were being neglected and mistreated, which isn't that surprising given kind of the attitudes that have been expressed here. So around this time, a woman named Cicely Saunders was caring for patients who were dying from cancer, and she became really concerned with how we weren't really treating and managing their symptoms effectively. She actually developed the idea of total pain, which you might have heard some palliative care doctors talk about, where the idea is it's not just physical pain that we have to treat, but also spiritual, social, existential pain as well. So she came over from London actually in the 1960s and talked to a bunch of Yale physicians about how to improve caring for the dying patient. In 1967, she established St. Christopher's Hospice in London, and this was the first modern inpatient hospice facility, and it ran only on donations. And this idea became very popular, and it spread across the pond, and in 1974, Hospice Inc. was opened in Brantford, Connecticut, right down the street from where I grew up, and it's now called Connecticut Hospice. And again, it was only funded by donations and charitable actions. But it became really popular, and the idea of inpatient hospices kind of spread. So you're probably thinking, well, these are all facilities. How did we get in the home? So at this time, as it became more popular, the founders of hospice recognized that they needed to secure funding rather than just relying on donations. And the best way they thought to do this was through insurance. At the same time, they also felt that not every patient needed to die in a facility. Not everyone had a lot of medical needs that required, 24-hour nursing care. And they had this idea that they would return patients to the peaceful dying at home vision that had kind of become popular. And hopefully I've kind of shown to you that this never really existed. And this vision really relied quite heavily on family members providing care and also assumed a certain level of socioeconomic status that just isn't attainable for many Americans. So the founders of hospice really felt that 50% of care should be provided at home and 50% of care inpatient. But in order to persuade Congress to pass any sort of legislation that would kind of mandate insurance to pay for hospice, they had to prove to a neoliberal and very fiscally conservative Congress that this would save money. And unfortunately, a 50-50 split didn't save money at all. It might improve quality of life and care for patients, but the dollars would still be the same. So there was a compromise. In 1982, Congress passed the Medicare hospice benefit, which was actually only for patients dying from cancer, and it stated that 80% of care would be provided at home. In 1986, this was expanded to cover non-cancer terminal diagnosis. So Medicare has saved, hospice has saved Medicare a lot of money. It saved $3.5 billion in 2019 alone, but it's actually estimated that if we paid family caregivers or replaced family caregivers with paid caregivers, it would cost about $600 billion. And so that's how much we rely on family caregivers to provide care. So hospice in the United States now kind of means two different things. So first, it's an insurance package for patients who are dying, and they enroll and kind of forego all their routine insurance benefits. So this can be Medicare, but also Medicaid and private insurance. And then the insurance companies will pay an outside agency a daily rate based on the level of care provided. And there are 4 tiers of care, from routine hospice care, which is what we typically think of for hospice in the home, all the way to general inpatient care. And that's really for those patients who are having uncontrolled pain crises, and they might go to like Evelyn's house here, for example. It's also a modality of treatment that really focuses on comfort rather than aggressive treatment, and really includes family in part of their treatment plan. There we go. So hospice agencies tend to be freestanding, so they're not associated with any other institutions. They're usually located in urban environments. And there's been a big shift in the past 20 years from not-profit or not-for-profit hospice agencies to for-profit. And this really has very important implications for care. So these agencies tend to provide fewer services and fewer nursing visits. They usually hire less experienced workers and will actually pay them less. And they tend to enroll less medically complex patients. So think the patient who has end-stage Alzheimer's, for example, versus a patient who may have multiple drains and needs dialysis, things like that. And family caregivers actually report worse experiences with these agencies. This is an overview of what a typical hospice agency looks like. So there's a hospice physician who kind of oversees all the patients, and then this interdisciplinary team consists of nurses, social workers, people like that who will go out and actually see the patient on a semi-regular basis. A hospice aide is something like a caregiver who can provide assistance with ADLs, but on average, patients see them about once a week for 30 minutes, which isn't that much support for ADLs. Hospice agencies provide all equipment and like medications, and then they also provide other support, like a 24/7 hotline that family members can call. They are supposed to provide access to an inpatient hospice facility, but only about 20% of hospice agencies actually have their own inpatient hospice facility. So it's very difficult for many patients to get access to. So these are just some things that hospice doesn't typically include. Notably 24-hour assistance with ADLs, but also some components of care that you could argue are palliative. So blood transfusions for a severely anemic patient are not typically included. Dialysis, palliative radiation, and they sometimes do provide enteral feeding, but it's usually case by case and based on cost as well. So now, what does that look like in practice? About 2 million Americans enrolled in hospice annually, and 75% of them die at home. I think it's important to note that the median length of stay is only about 17 days. And remember, you can have up to 6 months on hospice, so it's usually a pretty short amount of time. Family members provide nearly all care. And when I say all care, I mean everything from administering medications, this includes suppositories, doing things like wound changes or wound dressings and cleaning, managing bodily functions and fluids, all those sorts of things. And they don't usually receive a lot of training for this as well. A good minority of patients will die without seeing a hospice provider in the last 2 days of life, which is when they typically need the most support. And 1 in 6 patients won't receive symptom management when needed, which is kind of the whole point of hospice, right? So let's talk about the family caregiver, and this is where I became interested in this. I'm doing some research with the palliative department about how to improve support for family caregivers. The average family caregiver is in their 50s. They tend to be female and providing care to a spouse, but there's a good minority who are children, adult children, providing care to a parent. On average, they provide 8 hours of care a day, and this will go up to about 15 hours a day towards the end of life. Somehow, while providing all this care, about half of them are also working full-time or part-time. And many of them have to reduce their hours or go on unpaid FMLA in order to provide caregiving. So it's estimated that, including all the time before transitioning to hospice and while on hospice, the average family caregiver will forego about $300,000 in wages and benefits while providing care. And there are a lot of studies and qualitative research about what the experience is like for family caregivers. So they generally report they need more education about managing symptoms and what the dying process looks like. There's a lot of concerns about what the impact of medications will have on their loved one and if they will expedite the dying process. So this was a quote from a family member who said, quote, "I'm not a doctor and I don't know if I helped her go faster or slower or what." And I think that's really important to remember, that we're asking untrained lay people to manage really difficult to control symptoms that we as physicians tend to struggle with managing as well. So it's a lot to ask for them. Caregivers also report needing more physical support, especially with completing ADLs like bathing patients and feeding them. Unfortunately, hiring outside help is usually cost prohibitive for many family members, and unless they have other types of insurance like disability or long-term insurance, they typically cannot afford outside help. This all has really big impacts on their mental health and their physical health. So 1 in 3 meet criteria for depression, 1 in 4 will have anxiety, and 3/4 report moderate to severe sleep disturbances. And we know that this really impacts the care that they're able to give, and there's actually some literature suggesting that poor mental health in a family caregiver leads to poorer quality of life for the patient. These are some quotes from some qualitative studies that I thought really illustrated the experience. So, quote, "When I was caring for my mom, I was getting about 4 hours of sleep. When we started hospice, I slept in the same room with her. I was waking up every hour on the hour, especially toward the end, just to make sure that she was okay. Was she breathing? Did she need anything?" This was a quote from a gentleman caring for his wife. He said, quote, "There was no fallback. It's either me or nothing." And then this was a daughter caring for her mom, and she said, "There was no positive feelings. Even though in your head you say, I'm doing a good thing by taking care of her at the end of life, it still doesn't feel like a good thing. It just feels all bad." Okay, so I want to go into this field, so you're probably wondering why I'm kind of harping on about this. And I do want to emphasize that hospice isn't all bad, and hospice provides a lot of really good things. So we know that hospice improves quality of life for patients, and it does reduce hospitalizations, ER visits, and invasive procedures in the last months of life for patients. And it does overall decrease medical costs. And family caregivers report many positive aspects of caregiving, and some of these include increased family cohesion and a sense of personal growth and purpose in life. And this was a quote from a family member who was talking about how hospice really provided them with preparation. And so they said towards the end of this quote, "So it's preparation. That's part of the key word is preparation. Preparing to die and die with dignity. That's the biggest thing to me hospice offered." That's it. So can we keep patients at home on hospice? I'm not sure what we can do in the future. If the way things are going, it's going to be really difficult. People are living longer with more chronic and terminal illnesses, and more people than ever before are enrolling in hospice. In 1 year alone, there was an 8% increase in enrollment. At the same time, we know there's increasing housing instability, financial instability. More older adults are living alone, meaning that they don't have a spouse to provide care for them. About 30% of older adults live alone now. And families are living farther apart than before. So it's difficult for them to provide care, even if they would like to. There's also a pretty severe paid caregiver shortage if we wanted to pay caregivers. And part of this is because there are just more people who need care, but also because it's not a very attractive job. Caregivers aren't paid very well. The average salary is about $10 an hour, and there's a high rate of caregiver burnout, which makes it difficult to encourage people to go into this field. So I think there has to be a lot of change, and this is very lofty and idealistic, but I think starting from the top, we have to really think about the hospice structure and if everyone can die at home. And that also assumes that everyone would like to die at home. About 1/3 of Americans say they do not want to. And so rethinking what hospice can offer would be really important. So maybe paying more for inpatient hospice can make a big change. We could also start paying family caregivers, which the VA actually already does, and pay for more support through formal paid caregivers. When looking at agencies, they could provide more access to hospice aides rather than just maybe a weekly visit, and provide more training for caregivers so that they feel more equipped to manage their loved one's symptoms. But for you all, there's a few things we can do too. We can have more honest and early conversations with patients and caregivers about what hospice really looks like, so that way their families can prepare and kind of rope in as much support as they think they'll need. We can also encourage people who maybe have more time than we do to volunteer with hospice agencies. Volunteers will go to the patient's home. They might support them with ADLs or just provide companionship and a break for caregivers as well. And of course, you can also vote to help make some bigger changes too. So just in conclusion, hospice is really built on this idealized image of death that never really existed, but hopefully someday we can get closer to. I think in order to really support patients in the future, we need to radically overhaul the infrastructure to help patients die in a way that's in line with their goals while supporting their family. And I'd like to thank the chiefs for asking me to do this, and Shannon Devlin, Dan Padgett in the palliative department, my wife for listening to me talk about this, and Kylie Clevenger as well. These are my many references. And most importantly,
questions? Can we turn the lights on too? So I'll start with a question about VEXA. So what is it about men over the age of 50 that puts them at increased risk? And do you think this is something that could be diagnosed, before people are symptomatic? And if so, how would you do so?
That's a really good question, and I don't know if we know. So I assume that the reason it's more common in men over 50 is that, cancers are more common as you get older, and there's just a higher and higher mutational burden, and there's, more and more opportunity for your, gene replication to mess up, basically. So I think it's the same reason that cancers tend to increase with age, is the age question. Now, could we diagnose it earlier when it's pre-symptomatic? I don't know if we know, really, and I don't think we know at all the natural history of what things would look like kind of in a pre-symptomatic patient. So I think this is being researched, and we've seen clues of this in these big cohort studies where we look for genotypes, but I don't think we have had enough time of even knowing about the disease or enough information to really know what the true course looks like.
Thanks. Other questions?
Yeah.
oh, sure.
So the first question was a very sophisticated one about why it's the E1 enzyme of ubiquitination that's implicated in this disease, and what about the other enzymes. Once again, I have a poor background in molecular biology. My understanding is that the first step of ubiquitination is like a couple of enzymes, and then this cascades into a second step that's a couple dozen enzymes, and then that cascades into a third step that's like 1 million enzymes, approximately. And so, yeah, I think that's a great question. I assume they described this because, in their cohort, this is kind of like one of the master regulators. It's the highest up, so I imagine it has a more dramatic presentation when it's an acquired mutation. I think we have no clue. I've seen no literature on what the phenotypic variability of acquired mutations in the many, many other enzymes regulating ubiquitination is. I hope someone is getting several $1 million from the NIH to study it.
Not you? So the second question was, are there any countries that do home hospice well? From what I was researching, the answer is kind of no. It seems like everyone's really struggling with this right now. Most developed countries are having the same issue as older populations, not as many young people around to care for older adults and people who are on hospice. So I was looking at the UK and South Korea, and it seems like everyone is kind of in the same boat, at least from my kind of quick review.
Steve?
So Beth, I'm going to ask a question based on my own experience of transitioning people to home kind of care. So in the dialysis world, when we move people to home, they have to go through, both patients and family, a pretty rigorous training to be able to do that. What does that look like for family members who are taking care of people at home on hospice? Is there a period, is there a curriculum, is there something they can go through to help train them and prepare them for how to take care of their loved one?
So the question was about what kind of education and training do caregivers currently receive. I think it's more agency by agency. I'm going to say I'm not 100% sure about that. And I think from what the literature I was reading is it looks like the nurses who do the home visits do a lot of the training. So I'm not sure if there's a set curriculum or not.
So A question about home hospice. It seems like there are significant health disparities in terms of if you're wealthy and well-insured, then obviously you can hire additional people to help the family, whereas people who don't have those resources. So are there specific things we could do to try to improve access and support for home hospice for underserved patients?
So I think one thing that would be helpful is to pay caregivers. And so like the VA already does this actually, which is a really great model. And so that would mean that patients don't have, or their caregivers don't have to choose between having a job and also maybe still keeping insurance versus caring for their loved one. I think that would be one of the bigger steps.
Any other questions?
This is for Beth. In places where physician-assisted suicide is legal, is there a role for that within hospice care?
Ooh, that's a hot topic. I'm not sure because I didn't really look into it for this talk, but I imagine there probably is. Yeah, I don't have a good answer though.
Any other questions?
This question's for Gavin. So, from what I recall from my brief 2 weeks on DMT was that patients who got myeloseed first had a bone marrow biopsy that was sent to the flow, and then the pathologist decided if this was eligible for the myeloseed that you asked them to do. Is this the procedure for if you wanted to like secret people to VEXAS? Does it have to be done off a bone marrow biopsy?
It can be done. It can be done peripherally.
Repeat the question.
Sorry, the question was whether myeloseek can be done only off a bone marrow biopsy or whether it can be done peripherally. It can be done peripherally. You, Dr. Jin, could order it in Epic. You might get a call from the lab medicine resident to justify it, but it can be done peripherally.
It's not always paid by, unless there's an appropriate indication.
Yes, yes. I would fear to know how much it costs.